The proceedings are being broadcast. Before we begin, can I remind members to please switch off any electronic devices. Order, order. We now hear oral evidence from three witnesses. Alex Greenwich, who is the MP for Sydney in the Parliament of New South Wales, and two witnesses joining us via Zoom, Dr. Chloe Furst, who is a dual-trained geriatrician and palliative care physician in South Australia and a board member of Voluntary Assisted Dying Australia and New Zealand, and Professor Meredith Blake from the University of Western Australia. Could the witnesses please briefly introduce themselves for the record? And I'm going to start with Alex Greenwich. Welcome.
Thank you very much. My name is Alex Greenwich and I'm the member for Sydney in the New South Wales Legislative Assembly and was the person who introduced our voluntary assisted dying laws.
And Dr. Chloe Furst.
Hi, hello, nice to see you all. Yes, I'm a geriatrician and palliative care specialist in South Australia. I've been quite instrumental in the implementation of South Australians' voluntary assisted dying laws, and I'm a practicing practitioner with experience with over 150 patients.
Thank you very much. And lastly, certainly not least, Professor Meredith Blake.
Thank you very much. Nice to see you all. I'm a professor of criminal law and health law and policy in the law school at the University of Western Australia, and I have been writing, researching and presenting in the area of end-of-life choices for about 25 years.
Thank you. Before calling the first member to ask a question, can I remind all colleagues that questions should be limited to matters within scope of the bill. We have to stick to timings, as said in the programme motion, and the first session will finish at 12:30. So please, can we please stick to the point and keep them as short as possible. Members have indicated who wishes to ask a question, and I will call them in no particular order, but I have got a list of who intends to ask a question. And I'm going to start with Simon Ofer.
Thank you very much, Chair. And I'd like to direct this question to Dr. Furst, if that's okay. There has been some concern in this country about the efficacy of the end-of-life medication. So I thought I'd like you to just give me some of your experience in Australia about how effective they are and any problems you've encountered. Thank you.
Yeah, sure. The medications are completely effective. I have not had experience with any failures. It's one of the things that I feel quite comfortable reassuring my patients and their families is that this medication absolutely works. In terms of oral administration, which is the default option in South Australia, unless the patient themselves can't consume the medication or has problems with absorption, it puts them to sleep within a couple of minutes. They are heavily sedated like they are undergoing an anaesthetic, and then death ensues, i.e. the heart stops and respiration stops for about 95% of patients within about half an hour. There is a small percentage who will continue to be sedated for longer than that, but the heart won't cease, circulation won't cease for some hours after that. So we warn patients and their families, more importantly, that this may be the case, and that's sort of an enzymatic issue, but no, it's highly effective. Personally, I have not had any experience where patients have had complications, i.e. vomiting or respiratory distress or any other concerns, and certainly in South Australia that has not been an issue that's been reported to us. I think there's been a couple of cases of vomiting elsewhere, but it has worked in all cases as far as I'm aware around Australia as well. This has not been an issue. In terms of IV administration, again, that is highly effective, and by the time the medication has been administered completely, the patient is deceased. So this works, it's peaceful, and when patients say to me, I want to go to sleep and not wake up, this is absolutely what happens. It's a very peaceful death.
So just to confirm, Chair, is that right? Just to confirm, you haven't had any failures of treatment as far as you're aware?
No failures of treatment in South Australia as far as I'm aware, and I'm not aware of any sort of other particular ones around the country that have been really heavily broadcast to us.
Thank you. Thank you.
Naz Shah.
Thank you, Chair. Just to follow up on that, there's no requirement that the doctor is present when the person self-administers the substance which leads to assisted dying, am I correct? And if that is the case, what is the reason the law does not make it necessary for the doctor to remain present until death? Because at that point, the doctor would pick up them complications, would they not?
Yeah, so every legislation within Australia is slightly different. South Australia and Victoria, you're correct. There's pretty much no obligation all around Australia for a doctor to be present for self-administration. And the reason for that is to give individuals autonomy over their death and time and place of their choosing. We in South Australia do touch base with the individual's what we call contact person to understand if there's been any complications and to check in after the death. A large number of our patients though will seek out support from a nurse navigator, a voluntary assisted dying nurse navigator who is often there in the house present just as a sort of support person. So we do also have a lot of feedback from them as to any complications, but no, the doctor will often, or a nurse will come at a later time as well to declare life extinct. So the reasoning was that we didn't think that there was going to be complications. We wanted to give people autonomy, and we work on a permit system in a lot of jurisdictions in Australia, and so people have a permit. They get given their substance and they can take their substance at a time of their choosing. So they might have the substance in their house for weeks or months potentially. And again, there is no obligation to actually follow through with taking that substance, which we also think is quite important because we know in Australia about 30% of patients who have a permit or who are approved for voluntary assisted dying actually decide that they don't want to consume the substance, but it's actually giving them that choice and autonomy and strength to maybe pursue other lines of therapy.
Thank you. We've had lots of witnesses testifying about gaps in palliative care and end-of-life care provision here in the UK. What is the current state of palliative care and end-of-life care provision in Western Australia, please?
I'm in South Australia, but we know there was a recent survey done by Palliative Care Australia, actually, which surveyed over 900 palliative care specialists. And of patients receiving voluntary assisted dying, more than 80% of those patients are actually getting combined palliative care and voluntary assisted dying. We, in our legislation in South Australia, there's also key provisions that there would be monitoring of the funding to palliative care to ensure that no palliative care funding was diverted to voluntary assisted dying. But, we feel very strongly that palliative care and voluntary assisted dying should go hand in hand, and really that is a feeling that is being seen around the country now. Palliative care physicians that are finishing off training now see voluntary assisted dying as part of their core business. It's no longer seen as something that should be provided by separate practitioners, so it's really becoming quite integrated. I think Meredith wanted to also comment as well.
Yeah, I'm coming in from Western Australia. We were the second jurisdiction in Australia to introduce voluntary assisted dying laws, so ours have been operative since July 2021, so we've had the opportunity to collect quite a lot of data. Year on year, the number of people utilising voluntary assisted dying in Western Australia is increasing. In the year 2023 to 24, there were 292 deaths by voluntary assisted dying, which represented 1.6% of WA deaths. And I just want to agree with Chloe or confirm her view around the palliative care side of things. 83.8% of those persons who accessed voluntary assisted dying were also accessing palliative care.
Sarah Green.
Thank you, Chair. on that point about palliative care, actually, if I can direct my question to Dr. Furst, what's been the response from palliative care professionals to the introduction of assisted dying in Australia? We've heard evidence from people working in the sector in the UK, but I'm keen to hear what your experience has been in Australia, because I understand the Palliative Care Australia's National Workforce Survey explicitly looked at this, so I'd be keen to hear what their findings were.
Yeah, so I mean, I think it's been a journey, certainly. So Victoria started their voluntary assisted dying in 2019, and I would be lying if I said that the palliative care community were completely on board with it at that point. But over the last 5 to 6 years, there has been a real sort of shift in mentality, and I think we've seen that this can go hand in hand. Palliative care is about end-of-life choices. Voluntary assisted dying is about end-of-life choices. It's about putting the patient and the individual front and centre and working with them. And that is what's fundamental to palliative care. And I think as we've realised that voluntary assisted dying is just a promotion of palliative care, and it's giving them back choices. So, as I said, probably some of the older palliative care clinicians have not embraced voluntary assisted dying quite as much. That's probably very generalised, but certainly new consultants, new doctors that are coming through are really seeing this as something that they want to do. There's been no animosity, I don't think, anymore between the practitioners that choose to work in this space and those that don't. I get huge amounts of support from other palliative care physicians that don't necessarily act as practitioners, and there's no real divide. It's been embraced, really, to be honest, and I think in another 5 years there'll be probably very few palliative care practitioners that don't sort of support this unless they're true sort of conscientious objectors for their own, I guess, probably religious reasons. But yeah, Palliative Care Australia, the peak medical bodies within Australia, everyone has generally shifted to see this as part of patient choice.
Thank you.
Thank you very much. The journey to voluntary assisted dying in New South Wales, and indeed across every Australian state, has benefited palliative care access and funding. In New South Wales, 85% of people who have accessed voluntary assisted dying are receiving palliative care. As part of the process, the coordinating and consulting practitioner are also advising them on palliative care. The doctors are trained on the latest advances in palliative care. We have also, in the principles of our legislation, baked into it access to palliative care for all citizens of New South Wales. Importantly, throughout our debate, whether members supported or opposed the reform, our entire Parliament came together to ensure palliative care received an increase in funding and any access issues were addressed. So the Australian experience with voluntary assisted dying is it benefits and it strengthens the palliative care system.
Can I just add into that? The Voluntary Assisted Dying Board in WA, as in all the other jurisdictions, produces a report, and the very strong sentiment of the Voluntary Assisted Dying Board, and indeed within the West Australian community, is that voluntary assisted dying is seen as part of the end-of-life journey. So I can quote from the board's report that the statistics and the experience of Western Australians confirm that voluntary assisted dying is, quote, an established and enduring end-of-life choice. And for that reason, there's been quite a significant awareness that practitioners should be able to bring up voluntary assisted dying with the patient as part of that suite of end-of-life choices. That's been something which the evidence has suggested is very important, because if the practitioners are feeling that they can't raise it in that context, then that is having a detrimental effect on the patients who would like information on it. So that's been our experience in Western Australia.
Thank you. Thank you, Chair.
Thank you, Chair. My question is to you, Mr. Greenwich. I understand that in New South Wales, and please do correct me if I'm wrong, that similarly to the bill we're proposing, you adopted legalise assisted dying for those who are terminally ill and will die within 6 months, but you also added an additional criteria which was within 12 months for a neurodegenerative disease such as motor neurone disease. That element isn't actually being proposed in our bill, but we have heard from other witnesses over the previous days about that kind of issue. What sort of reflections might you have regarding that, and whether you found, and why did you add that element into the bill beyond the kind of 6 months that we're proposing here?
Well, thank you very much for your question. And at the outset, I'll just stress that every jurisdiction should legislate the form of voluntary assisted dying that is appropriate to them. In New South Wales, that was 6 months for a terminal illness, or 12 months if that terminal illness was a neurodegenerative disorder. We had learned from the other schemes in Australia that was going to be important because of the decline that occurs in neurodegenerative disorders like motor neuron disease, for example. So it was because of that we went down that path.
I should add that in Queensland there is no such distinction in life expectation between other diseases and neurodegenerative diseases. So Queensland legislation is different. It sets a 12-month period of expected death, and the reason for that approach was in response to feedback from people living with neurodegenerative disease that they felt that they were being put in a different position to people suffering from or experiencing other terminal illnesses. So the Queensland Parliament did take a different approach to address that particular feedback.
And I guess from South Australia's perspective, we are similar to New South Wales. We have less than 6 months for all conditions bar neurodegenerative conditions, which is less than 12 months. As a clinician, personally, I think that 12 months for neurodegenerative conditions is really helpful because, as you've sort of heard, I guess if you're looking at prognosis and trajectories, with things like cancer, a patient will sort of be going along and then often have a quite steep and rapid decline, and it's quite noticeable, that sort of 6 month prognosis. But for patients like motor neuron disease, their decline can be slow and very distressing to them, and also trying to balance the prognosis along with getting them through the process. 12 months is really helpful. So I think if there was any chance, I would be strongly advocating for that.
Thank you, Chair. Thank you to the witnesses for joining us this morning. I'd like to address my comments to Alex Greenwich, if I may, but also come back to Dr. Furst and Professor Blake as well. I think what's really valuable for us as a committee is to hear your reflections on the experience of the process of passing this legislation and your reflections on that. And how did you manage to keep that process patient-centred, but also take into account the concerns around the broader societal issues, particularly when it comes to equality and human rights and those really important issues as well. So what was that process like, and what are your reflections on it? And then if I may, to Dr. Furst and Professor Blake, one thing I feel really strongly about is having really good training around assisted dying and end-of-life care and choice. So any comments you'd like to make on what that looks like? So maybe to... Thank you.
Thank you very much for that question. I'll take you through a little bit of the journey to voluntary assisted dying in New South Wales, what encouraged action, and then the safeguards that we put in place. The New South Wales coroner had reported to us that there were a number of really horrible suicides of people with terminal illnesses who felt they had no option, that those were cruel and lonely suicides. That was backed up by paramedics and police who would arrive on site. Myself and my parliamentary colleagues decided we can do better and we can regulate in this space. Voluntary assisted dying in New South Wales is an important form of suicide prevention. What voluntary assisted dying does, in the model that we legislated, is it ensures a person who has a terminal illness, who knows that it is going to be a cruel and painful end of their life, is instead directed to a doctor who will be able to take them through all of their palliative care options, who will be able to provide them and link them with social supports, and who will give them the choice to have a death that is better than otherwise their illness would provide. It has been important to make sure that our legislation is limited to that cohort of people who are terminally ill, who know they will have a cruel end of life. Our legislation is not about people with anorexia nervosa. It is not about people with a disability. It is not about people who are feeling a burden. It is about a very limited and narrow cohort of people who know that they are going to have a very cruel and painful end of their life and want that control to know that they can have a death that is better than what their illness would otherwise provide. We've ensured that decision-making capacity needs to be enduring. We've ensured that a person cannot be under any form of coercion. We've ensured that we had a really strong period of implementation from the time the bill was passed. 18 months later it came into effect to make sure that our health system and the various doctors required training. So in New South Wales, the experience of voluntary assisted dying has been that it has been a form of suicide prevention, and that it has also been, as I explained earlier, very pro-palliative care. As I reflect on our parliamentary debate, it was also one of the first times our parliament had grappled with the concept of death. And we were very honest about it, and we were very honest in having to admit that we're all going to die, and there are some people with some illnesses, some terminal illnesses, who are going to die in a really cruel and painful way, and that we could provide them with an option of control, peace and respect. And we believe, and our annual reports into our legislation indicate, that we have been able to provide that. I'm happy to answer any further questions, but I might wrap up on that.
Meredith.
Yeah, thanks. I'd just like to, given that the West Australian legislation has been in force rather longer than the other jurisdictions that have been talked about today, we have had the opportunity to reflect upon, and I'm speaking here as a lawyer, I assume that's why I've been invited to talk, and that has revealed some of the very good things about the working of the legislation, but also some of the challenges that have emerged. The legislation in all Australian jurisdictions, as Dr. Furst has said, is slightly varies, but follows a particular legislative model, I would say. And it is highly prescriptive. It requires a number of requests, and it requires the assessment by, in Western Australia, 2 different practitioners. In Western Australia, there is no judicial double checking of that process, and although I note that that is contemplated within the UK law, that is not something that we have found to be necessary or even appropriate in Western Australia, and I think that would be the case in other Australian jurisdictions. But one of the issues that we have experienced is that there is the struggle to get people taking up the training, whether that be medical practitioners or nurse practitioners. And one of the thoughts around that has been the very prescriptive nature of the model, which does require a lot of work on the part of the practitioners. So I think it's worth bearing in mind when you're looking at your piece of legislation that the more prescriptive it is, the more that work that is requiring on the part of practitioners, and that is a lot of work, and we need those people to undergo the training in order that the process is done properly and that all of the safeguards which are included within the legislation, and they are extensive, are respected. So I think that that is something to bear in mind. And we have, prescriptive provisions around capacity, around voluntariness, around lack of coercion. And I would add that we also have a requirement around residency, and if we're looking at when the legislation has come before a tribunal or a judicial body, the only circumstance in Western Australia at least where that has come before the tribunal, which is the State Administrative Tribunal, has been where the practitioner has regarded the patient as not eligible on the grounds of not fulfilling the residency requirements. There has been no other ground on which a matter has been taken to a judicial body. In terms of the training, you asked about that. That is an essential requirement for practitioners who are involved in making assessments and involved in the whole process. That is something that is intrinsic, I would say, to the operation of the Act, and I think that the feedback that I've heard is aligned with what Dr. Furst has said, is that there are no divisions that have arisen within the practitioners here, and that those who have chosen to do that training are indeed very valued, I think, and very much appreciated by the people who have accessed the scheme. I'll just say two more things around the regulation before I pause. One of those is that the report that has been handed down, the only negative feedback has been around delays, and that has been identified as being due to a lack of education amongst professionals, health professionals. And so one of the recommendations of the report is that education around that really needs to increase so that people's journey on VAD is not unnecessarily delayed, and indeed where perhaps their wishes are not able to be granted. The second thing I'll say is around conscientious objectors. 13.7% of applications for VAD in Western Australia from 2023 to 2024 were declined on the basis of conscientious objection. But in Western Australia, unlike some other Australian jurisdictions, if a practitioner declines to become involved in the process, they are required by law to give the patient an information sheet outlining options around voluntary assisted dying. So that is actually mandated in the legislation. I think I've probably said enough for now, so I'll hand over to Chloe.
Thank you. I just picking up on the training, completely agree with Meredith. The training is fundamental for, I think, most jurisdictions. It probably takes a full day. It's often an in-person sort of event followed by an exam, and you have to past that, and we in South Australia had a whole lot of mandatory questions that you actually had to pass to be able to be eligible, to make sure that you were upholding the legislation. This is so different to anything else in medicine. So in any other part of medicine that I practice, if I see a process that I think can be improved, and if I see efficiencies that can be done, or if I see bits of the system that really are not adding to the patient care, I can just choose to kind of adapt the process as I see fit, to give the care to the patient that I want to give, or that's compatible with what the patient wishes. That's so different to voluntary assisted dying, where, as Meredith said, it's so legislated, down to who can be a witness for various documents. Again, as a doctor, the amount of documentation that is required for voluntary assisted dying is just second to nothing. We just don't do this kind of documentation in any other areas of medicine. So it's quite different, and it really does require being quite precise around that documentation and making sure that you're meeting all those time frames and guidelines. So that is, the training is hugely important in terms of the operational component. I think there's also the training around end of life and conversations, and actually how do you support the patient, how do you support the families, and that is obviously a lot harder to teach. And that's, I guess, why people will fall into this, and that's why a large number of palliative care doctors will actually do it, because it's already second nature to them, or they've already got the relationship with the patient. They see these conversations as being something that they're good at and facilitating it. So, there's two parts of that training that are really important. And then I think there's also the training that we need to be giving, as Meredith said, to the rest of our workforce and really all health practitioners, because, a patient might ask the social worker or the orderly or the dietitian about assisted dying, and they've got to know how they can respond and how they can connect that individual to the right practitioner. So that's really important, and we've done a lot of work in South Australia, as all the other jurisdictions, around upskilling sort of the whole workforce, because this is everyone's role and job. I guess I just also wanted to speak very briefly on sort of what we in South Australia call the gag clause. So in South Australia and Victoria, we're not allowed to bring up voluntary assisted dying with patients, and that is really, really problematic. And from my perspective, it really leads to, poor provision of care. In medicine, when I am talking to a patient, in every other area, if they needed treatment, I would be obliged, and it would be good practice, to actually tell them about all the treatment options that are available to them. So if someone had cancer, I would want to be telling them about good palliative care, potentially surgery, radiotherapy, chemotherapy, and yet voluntary assisted dying is the one thing that we're not allowed to talk about, that's taken off the menu. And so some people may not know that voluntary assisted dying is available to them. They might be waiting for me as the doctor to bring it up to them, because I've brought up every other option for them. Why am I not able to talk about voluntary assisted dying? And I just think that is really important, that we don't stigmatise voluntary assisted dying, and we see it as a valid option for people.
Colleagues, before
just to add on to what Chloe said there, in Western Australia, practitioners can raise voluntary assisted dying as long as it's in association with other end-of-life choices. But the way that the legislation is worded is confusing, and so one of the recommendations in the most recent report is that that be removed altogether, so that voluntary assisted dying is just treated like any other treatment option, because the evidence was, as Chloe indicated, that by treating voluntary assisted dying differently, the whole end-of-life journey can be compromised, because it actually interferes with other end-of-life discussion of other end-of-life options. So the strong recommendation from the board is that this be removed altogether, and that voluntary assisted dying be treated just like any other appropriate treatment option, so that the patient has a true choice.
Colleagues, before we continue, we have 13 questions and we have less than 30 minutes. So question and answer needs to be 2 minutes, no more. and I'm going to call Daniel Francis.
Thank you, Chair. I just wanted to ask about capacity. I think you said that patients are given the drug, in some cases, sometimes before they die, Chloe. So just really understand where capacity assessments are taken on what stage during the process.
Yes, so capacity assessments are taken at every time a doctor sees the patient, which in my state would be at a first assessment, first request. Then a consulting doctor would come and do another kind of hour-long assessment of that patient and assess capacity at that stage. And then I would come back as the coordinating doctor for a sort of a second or third assessment of the patient and assess capacity. They would then be given their drug if it's self-administered, and they, we assume and we hope that they retain capacity, and we advise strongly to patients and families that should they lose the capacity, that they've sort of voided their permit and they can't take it, but there is less oversight of that. However, we know that majority, over 80% of these patients are connected with palliative care, and so we have community teams often going in and seeing these patients, and we're still kind of touching base with them maybe more peripherally and checking capacity as we're having conversations or as we're coming and doing home visits from a palliative care perspective. If it was deemed that the patient was quite delirious, then the permit would be again sort of voided and we'd remove the substance from the house. If it's practitioner administration, then we're also obviously testing capacity right at the moment that we're administering the substance.
Thank you very much, Chair. And can I direct this question initially to Mr Greenwich? And it's around the issue of coercion that's been a significant concern to many in the debate. In line with the New South Wales legislation, the bill that is as proposed doesn't provide a definition of coercion, either explicitly or by reference to other legislation. Have you found that to pose a difficulty in your jurisdiction? I wonder if you can comment a little more around that.
Yeah, no, in New South Wales, our legislation deals with and goes through coercion in quite some detail with pathways to be able to assess it. It could be that our legislation, for example, deals specifically should someone be, under coercion from someone who is a beneficiary of their will, then obviously that the person seeking voluntary assisted dying becomes ineligible. In the space of coercion, that is a key part of the training for a doctor who will be a consulting or coordinating practitioner. We've made it a criminal offence in New South Wales as well. And indeed, our board will report on it and whether or not eligibility for access to voluntary assisted dying has been denied to someone. And in our most recent report, it indicates that it has. I would say the overwhelming experience is that having voluntary assisted dying in place in itself is a safeguard from coercion for people with a terminal illness. If someone is wanting to end their life quickly, voluntary assisted dying through a regulated process is not the option they're going to take. Someone engaging in voluntary assisted dying is going to be assessed against coercion, is going to be assessed amongst decision-making capacity, is going to have to make sure that it is an enduring decision. So I would argue that when we talk about coercion and your concern of people with a terminal illness in any way feeling coerced, as they currently may very well be in the UK, the experience in New South Wales and in Australia is voluntary assisted dying has provided a safeguard in this regard, and our legislation, the training, the reporting is very clear on that.
Thank you very much. 1 minute with Dr. Furst, please, and then 1 minute with Mr. Greenwich. Dr. Furst, I've had a look at the reports of the South Australia Voluntary Assisted Dying Board. There's no data there that I could find on referrals for additional assessments of eligibility or decision-making capacity or reasons why people were considered ineligible. And there's no provision for reporting on complications, the time between the administration of the drugs and loss of consciousness, or the time between the administration of the drugs and death. And as we've heard, there's no requirement for a doctor to be present. So I don't understand how you can say that there's no evidence of coercion or of issues around capacity or indeed of complications at the death. You clearly don't collect the evidence on these things.
I don't think that's the case. We are seeking out from relatives within a month normally from around any complications. We are also, as I said, informally speaking to the nurse practitioners that are on site, but I don't think it's been published as part of our state report. Okay. So in terms of coercion, I would sort of say that it's much more likely that patients are being coerced into invasive, intensive treatments like cancer, like chemotherapy, than being coerced into voluntary assisted dying. Okay. And certainly when
Thank you for that very much. Mr. Greenwich, you said a couple of things. You said that voluntary assisted dying supports palliative care in terms of funding. I read that, in fact, while New South Wales committed to spending an extra $743 million on palliative care, in fact, the budget was cut by $249 million in 2023, and at the same time, New South Wales allocated $97 million in new funding to assisted dying. So I don't understand how you think that palliative care was benefited from this introduction. And you talked about suicide prevention. The fact is that unassisted suicide rises in states that have assisted suicide laws because suicide is contagious. It's too early to tell what's happening in New South Wales, but in recent years in Victoria, unassisted suicide rose by 50%, while in New South Wales, before they had this law, it stayed the same. So again, I don't understand how you think that it helps with suicide. We've just heard about the so-called safeguards, and we heard yesterday from Australian colleagues. Do you agree that the safeguards that were introduced were in fact impediments to access and that it would be the right thing to do to remove them?
I will try in the time to answer all three of those, and happy to provide more information on notice as well to you. In terms of the palliative care funding, it is accurate that New South Wales had a record boost in palliative care funding. Not all of that could be expended as the workforce was being trained up, but that commitment from all sides of our parliament is there, and you can always seek to improve palliative care funding, and that in no way should be competing at all with voluntary assisted dying. When it comes to the question of suicide, as I addressed in my opening statement, voluntary assisted dying is a form of suicide prevention. If someone is wishing to end their life, voluntary assisted dying is not the process they're going to take. It is a process that provides a safeguard to ensure people are getting full information on palliative care and are getting social supports. In terms of the safeguards in our legislation and proposed in your other legislation, it's really important that you have in your head and in your heart the experience of a person with terminal illness who is going to have a cruel and painful death. We are talking about people who are dying and who are wanting to have a death better than what their terminal illness would otherwise provide them with. We're talking about a small cohort here who we in New South Wales sought to give peace, dignity and control to, and we're really proud that we did.
Can I remind colleagues to stay within scope of the bill, please? Kate Malthouse.
Thank you, Chair. I just want to go back to this issue of gag clause stroke doctor initiation. Alex, could you just quickly talk to us about the thought processes, why, if you can, why some states introduced it and why you didn't, and how in legislation you have circumscribed the way doctors should approach this with patients. And then perhaps to our two medical guests, if you could talk about how in territories where there isn't a gag clause, doctors are obliged, if you like, not to lean towards a particular recommendation as they might do in other courses of treatment.
Thank you very much. Our experience in New South Wales was based on evidence from doctors and people with the lived experience of a terminal illness. It is an extremely confronting thing to be told you have a terminal illness, to be told you have 6 months to live, to be told, for example, if you have advanced bowel cancer, that your end of life will look like you are going to be choking on your own faeces. In New South Wales, we decided that it is important that that person who has been told they have a terminal illness is able to have a fulsome conversation with their doctor about all of their options. And one of those options being the provision that they could have a better death than their illness would otherwise provide them with. So being able to really talk through with your doctor all of your options, from access to palliative care, to social supports, to what the process of voluntary assisted dying looks like, we decided was so important, and we believe is working really well in practice. We would be concerned to gag those conversations, as those would ensure that patient is not receiving the fulsome information about their end-of-life choices.
Sorry, just to intervene slightly, but how did you approach that in the legislation? Is it silent as to what doctors should do, or does it have a prescription in the legislation about what they have to do?
In our legislation, we make it clear that the doctor has to, make sure the patient is aware of their palliative care options. We have referral pathways as well for psychosocial supports. All of that is prescribed in the legislation. Obviously, in the training for voluntary assisted dying, a lot of this stuff is covered. We also, in the legislation, sort of define the things we want to have in that training.
Thank you. Doctors.
Meredith, do you want to go first and talk
about? I will. In Western Australia, which was the second jurisdiction to introduce...
I'm sorry, Meredith, we've got to move on to the next question because there are other members waiting to ask. Tom Gordon.
Right, okay.
Thank you very much, Chair. The question's probably more for Alex. I just wondered, in terms of when you were coming to the criteria and safeguards in the bill in your state, how that then interplayed with other regions and other states nearby. Obviously, in the UK, we have laws. The bill that we're looking at would be applicable to England and Wales. Scotland have their own assisted dying bill that's happening at the minute, and we'll hear later on about that. I just wondered if there was any sort of information, or if you could talk about how different states, different regions interplay with each other when they have assisted dying laws.
Thank you very much. Well, New South Wales came last in the nation when it came to adopting voluntary assisted dying, and that was actually beneficial because we were able to draw on the experience of both, particularly Victoria and Western Australia, to make sure things like the gag clause weren't in place. I would say, and with all respect to the introducer of the bill, this, as a result of the Australian experience, is not revolutionary law reform. It has been tried and tested. We have appropriate safeguards in place throughout Australia, and they work.
And I just think on that, obviously...
I'm sorry, there's only another question. Rachel Hopkins.
Thank you. And this is directed at Chloe about the practical application of access to doctors for patients to be able to, because that's suggested in our proposed legislation, and how they have those conversations with patients, particularly as a geriatrician, older patients. We heard from somebody yesterday who said there was concerns around how older people were treated and potential risk of elder abuse. So I'd be interested in how the practical application of those conversations were had in your experience.
So a patient has to specifically ask me about voluntary assisted dying first up, so they've got to use words that really imply that this is what they want. I will often ask any relatives to leave so that I can actually have a conversation just with them and then invite family back, just to again sort of try and reduce that risk of coercion. One of the practical things I often ask them is, when did they start thinking about this? Is this something that they've always considered should be a right, or is it more of a newfound sort of belief given their current suffering? I want to understand what their current suffering is. I ask specifically, do they feel a burden on their family and friends? It's an hour plus long conversation to really understand them and their suffering. Making sure again that they understand all the other treatment options that are available to them, what good palliative care looks like. I will often be prescribing other medications as part of that, so good palliative care and opiates and anxiolytics. As a geriatrician, I'm also making sure that their mood is also addressed, and that this isn't sort of a reactive depression. So you're really doing a holistic and what I would call a comprehensive geriatric assessment as part of that voluntary assisted dying assessment as well.
Hi, this is a question for Dr. Furst and Professor Blake. Many of us on this committee are committed to the need to protect disabled people and ensure this bill has as many safeguards in as possible. We heard evidence yesterday that anorexia may qualify under assisted dying laws in other jurisdictions. Have there been any cases of people with anorexia accessing assisted dying in Australia? And in your view, do the respective laws across Australia allow for it? And secondly, particularly for those with learning disabilities, are there any lessons that we can learn on building in safeguards to this bill in relation to that group?
So all around Australia, mental health is, as the primary terminal illness, is excluded. So anorexia by definition is excluded. I have had a patient come to me with anorexia as their terminal illness requesting voluntary assisted dying, and it is a relatively easy assessment because they do not meet the standard criteria, and I was able to explain to them that they were not eligible. But again, it does open the opportunity to have good in-depth conversations with them about what they're going through. I can't talk probably to the learning disabilities other than to say that every time a patient comes to me, it's really a directed to that patient. So, I saw a patient today with motor neuron disease that is on continuous BiPAP, that is using eye gaze. The assessment and the conversations that I have with her are based around what she can do for me. I've had patients that have been able to use a thumb up and down. I've had trachea patients. So I can't talk about necessarily learning disabilities, but you, as a holistic practitioner, are trying to make sure that the patient in front of you understands everything and is given a full opportunity to express their wishes.
Yeah, and I'll just say as a matter of law...
I can only take one answer. Meredith,
okay.
we haven't got time. One answer to one question. Sergeant Joseph.
Thank you, Chair. Maybe I just follow it on from the answer you said, Dr. Furst, about anorexia. I know anorexia is not classified as one of the terminal illness, but long-term starvation can lead to severe physical health conditions, and patients may end up in palliative care. Do you have any experience of those cases in Australia?
We have experience of those patients in palliative care, but I would still say that they're not eligible for voluntary assisted dying, and none of us would feel comfortable because it's got to be an irreversible condition as well. And again, capacity-wise, you'd have to make sure that they have capacity, and I would question whether someone that is anorexic truly has capacity around their illness.
Thank you. The question for Mr. Greenwich, if I may. I think we're minded that, as well as passing really good legislation, we want to try and keep public confidence or get public confidence behind this. And I think we've heard a level of concern from disabled people's representative bodies around the implications of this law inadvertently for disabled people. I just wondered if you could quickly share any reflections on if those concerns were shared when you took your legislation through, and how that's gone since the implementation of the legislation.
Yeah, thank you. So in New South Wales, like across Australia, having a disability or having a complex mental health issue like anorexia does not make you eligible at all for voluntary assisted dying. The legislation we are dealing with, the legislation you are dealing with, is not for people with a disability. It's not for people with anorexia nervosa. It's not with people who have a burden. It's for people with a terminal illness who may want the choice of a death better than their illness would otherwise provide. We worked closely with disability groups in New South Wales. Their main concern was that they would be treated equal in terms of access to the law if a person with a disability had a terminal illness. And I guess the key thing here is this legislation is a safeguard to those concerns, to the point about people who are starving themselves. That is happening today in the UK because people do not have access to voluntary assisted dying, so they are starving themselves to death rather than accessing a regulated scheme where they can discuss all of their options and all of their choices.
Jake Richards.
I think this question is probably best for Alex. Yesterday we heard evidence about the health inequalities in our society and fears that would be exacerbated by the introduction of assisted dying. I just wondered what the experience was in Australia.
Well, look, if I think of our health system and how we adopted voluntary assisted dying, like all health systems, we were under pressure following the COVID pandemic. In legislating in this space, you are able to give your health system the priority to be able to deal with it, to make sure doctors are trained to be able to address it, and to make sure that you've got a good implementation period. I believe the bill has 2 years. I think that's completely appropriate to be able to make sure your health system gets up to speed. So I think what voluntary assisted dying does when it comes to end-of-life choices and healthcare is it provides a great deal of honesty and it provides a great deal of safeguards.
I think this will probably be the last question, and I'm going to call Sean Woodcock.
Thank you. This is for Meredith Blake. Does it concern you that a large proportion of people who opted for assisted dying cited being a burden as their reason?
That's not the evidence that we've got.
Well, if I may just clarify, the state's own report in 23-24 had 35%.
What we've got in place is we've got a system whereby at least 20 case studies are examined by the board every year to look at the reasons behind the taking up of the option, to look at how the system's working, and that as a check, and it's at least 20, that as a means of checking up on how the system is working, has proven to be very workable. Now, there are people who feel that they are a burden. People can feel that they are a burden, and they are actually, that is part of their autonomous thinking. People have their own views of their own life, and if the system that's in place is adhering to the very well established tests for valid decision making in healthcare generally. And that is what I'm saying, I suppose, is that if we are talking about people making decisions because they feel like they're a burden, well, people make decisions about their healthcare in all sorts of contexts. And we have a system of ensuring that decisions are valid that has proven to be long-standing and successful. And that is that the person has capacity, that their decision is voluntary, and that they are informed of the relevant facts and information. Now that is a test which has stood the test of time, and that is one which our legislation and the legislation throughout Australia seeks to also replicate. But I would add that with our voluntary assisted dying laws, there is a very, very clear emphasis on the information which the patient is entitled to. So the information which the practitioner has to give to the patient is extensive. It must go through the palliative care options. It must go through to them what voluntary assisted dying involves, and it must also include discussion of what if the voluntary assisted dying moment doesn't work. So it's a very extensive list of matters which must be discussed by the practitioner, and I'd say that in no other sphere of medicine where a patient is working with their healthcare practitioner does this level of informed consent apply. So I think that in terms of medical practitioners ensuring that people have the capacity to make the decision, making it voluntarily and have all the relevant information at their disposal, we cannot find anywhere in any other context of healthcare the level of safeguards and protections that we find in this sphere. And I think that if there is people that are saying that they're a burden, that does not mean that their decision is not voluntary. That does not mean that they don't have the capacity. It simply is an expression of how they feel. The key thing is not whether they think they're a burden. The key criteria are whether they have the capacity and whether their decision is voluntary and free from coercion. And health practitioners make those assessments all day, every day.
I'm taking that as a no.
Can I remind colleagues, it's unfortunate that I have to interrupt a witness. It's unacceptable for a member to interrupt a witness once they've started answering. Order, order. That brings us to the end of the time allocated for the committee to ask questions. I thank all witnesses on behalf of the committee for their evidence. And as there are no further witnesses this morning, I invite Kit Malthouse to propose the adjournment.
Chair, I understand a wrinkle in standing orders means that I must beg to move that further consideration of the bill be now adjourned.
The question is that the further consideration of the bill be now adjourned. As many of that opinion say aye. Aye. On the contrary, no. The ayes have it, the ayes have it. Order, order. Members will meet back here. Can we remain seated until we finish? Members will meet back here in half an hour for the final session of evidence taking. Can you please sit down when the chair is talking? Thank you.